think in the interest of time, we'll go ahead and get started and others can join as they're able. Okay. Hi, everyone. My name is Melissa Varnum and want to just welcome everyone to today's Oregon Office of Rural Health's bi-monthly community conversation webinar. Today, our community conversation is focusing on our office's rural EMS and mobile integrated health or MIH programs. As I mentioned, my name is Melissa Varnum, and I am ORH's Rural MIH Program Coordinator. And I'm joined today by Joan Field, who is ORH's Rural EMS Program Coordinator. Also joining us today are presenters from Mercy Flights, Umatilla County Fire District 1, and Scappoose Rural Fire Protection District, who are going to be sharing about their MIH programs and who we will introduce a little bit more here soon. So before we get started with today's presentation, I wanted to just go over a few quick logistics. The audio has been muted for all attendees. You can select the speech bubble button on the bottom right of your screen to open the chat feature. We will be monitoring the chat for any questions and we'll hopefully have some time toward the end of the presentation to go through any questions in the chat. When it is time for questions, you can also opt to raise your hand by clicking the button at the bottom of the screen, and we'll then ask you to unmute so that you can ask your question live. In the event that we are running short on time, we will also be putting our presenters' contact information into the chat, so you'll be able to connect with them after with any questions that you may have. The presentation slides and recording for today's webinar will be posted shortly after the session on ORH's website at the link on the slide. And we will also put the link in the chat here in just a moment. Okay, so as a little bit of background, the Oregon Office of Rural Health has a long history of supporting rural and remote Oregon EMS agencies, including through our Helping EMS in Rural Oregon or HERO program, which provides training grants of $2,500 each to rural EMS agencies annually. By administering the Oregon Rural Volunteer EMS Provider Tax Credit Program, through our Medicare Rural Hospital Flexibility or FLEX program, and by providing partnered progressive simulations, most recently focused on OB care for rural hospitals and their transporting agencies. Okay, and I'll turn it over to Joan. Oh, you're muted, Joan.
Oh, let's try that again. Hello, everybody. Just to give a little bit of context, this is a map of the rural EMS system in Oregon. Oregon's 104 licensed, hold on here, my computer screen just went goofy. 104 licensed rural transporting EMS agencies are critical to assuring access to healthcare in rural Oregon. Of these 104 transporting agencies, 84 operate in rural and 20 in remote or frontier ambulance service areas. As with the hospitals they transport to, the size of these EMS agencies' coverage areas presents steep challenges. Coupled with heavy reliance on volunteer personnel and fluctuating resources, many agencies struggle to maintain operational capacity. Remote and frontier demographic challenges also make recruiting new personnel difficult. When you have fewer than 6 residents per square mile, which is the definition for remote, that potential new EMS student must often travel to another county, sometimes 2 hours away each way, primarily at their own expense, to complete training and obtain certification. So ORH's current rural EMS program is primarily funded through the Medicare Rural Hospital Flexibility or FLEX program EMS supplement grant, which focuses on EMS workforce recruitment and retention. This is that I facilitate. The grant, which began September 1st, 2024, is set to operate through August 31st, 2029, pending congressional approval of funds on a yearly basis. Later this year, on September 1st, 2026, the grant will enter its third fiscal year, and so much has been accomplished. More than I can share here today, but I wanted to give you just two quick statistics. Through this grant's EMS Education Scholarship Program, to date, we've supported 40 rural EMS providers to either begin or expand their EMS certifications. And this spans from EMT through paramedic. And with this grant's assistance, there are at least 33 new EMR providers serving in rural Oregon agencies across Oregon, and so much more. But today we're here to talk about EMS and mobile integrated health, or community paramedicine, which are closely aligned. And MIH is only one of the EMS recruitment and retention strategies that our presenters will share more about today. I'm going to put a link in the chat that is to the 2025 community conversation that gave a little bit more information about the EMS grant.
Okay, and I am going to share a little bit more about ORH's Rural Mobile Integrated Health, or MIH program. So this program was developed from an initial project that our office worked on with the Oregon Coalition of Local Health Officials. And the focus of that project was supporting the training and the cross-training of community paramedics and community health workers. And it was through this work and working with these partners that ORH was introduced to and became more engaged with MIH care models, which really aim to train EMS and healthcare staff in an approach that brings healthcare services directly to patients in their homes, in an effort to reduce hospital readmissions and non-emergency EMS calls for patients who are, sometimes frequent users of EMS services. And we'll hear more about, the different particulars and specifics of MIH when we hear from our presenters here in just a minute. But, MIH providers and community paramedics are able to visit patients in their homes to provide things like health education, to support them in managing chronic conditions, and to help connect them with community resources. And you'll often hear, or I have often heard, as I've been learning more about MIH, that if you've seen one MIH program, you've seen one MIH program. And one of the strengths of this approach is really its ability to be responsive to a community's needs and to help fill those gaps. So ORH was awarded a 4-year grant in August of 2025 through HRSA's Federal Office of Rural Health Policy. And through this grant, ORH is working in close collaboration with the Oregon Mobile Integrated Healthcare Coalition, which you'll also hear more about today, to develop and share an MIH toolkit and technical assistance for rural organizations and EMS agencies that are interested in starting an MIH program, or expanding one if they have kind of started one. In addition, we're also working closely with partners in Wheeler County to establish a pilot MIH program. ORH also recently received a Catalyst Award from the Oregon Health Authority through the Rural Health Transformation Program to support the establishment of MIH programs in Grant and Harney counties, and then also to expand that pilot program in Wheeler County. Okay, so we are going to transition now and hear from our 3 presenters about their MIH programs and how their programs support their agency's recruitment and retention efforts. So we'll first hear from Sabrina Ballou, who manages Mercy Flight's Mobile Integrated Healthcare program and chairs the Oregon MIH Coalition. As a certified community paramedic and community health worker, she has helped build one of Oregon's leading MIH programs, focusing on innovation, compassionate care, and data-driven coordination to improve health equity. Next, we'll hear from Jessica Markham, who started her career in EMS in 2008 and obtained her paramedic certification in 2010. Her community paramedic program in Umatilla County began in 2017 and is still active today. She recently obtained her community paramedic certification through the IBSC. Jessica serves as a board member for the Oregon MIH Coalition, where she is excited to help bring sustainability to all community paramedicine and MIH programs in Oregon. And then finally, we'll hear from Nina Kerr-Bryant, who has been working as a Columbia County community paramedic since 2017. She has been a paramedic since 1983, and even as a 911 response medic, has seen the value of mobile integrated healthcare for individual clients, the people who respond to and care for them, the communities in which she works, and the healthcare system as a whole. And with that, I will turn it over to you, Sabrina.
Thank you. Thank you for being here, everyone, today. I'm actually really excited to share. I get to share a little bit about our program, and then I get to share a little bit about the Oregon MIH Coalition and our goals. So as Melissa mentioned, my name is Sabrina. I am a community paramedic. I am also a CHW, and I do chair the Oregon MIH Coalition along with managing Mercy Flight's mobile integrated healthcare program, which started in 2016. Next slide, please. So for Mercy Flights, we actually serve in Southern Oregon, and that is most of Jackson County, except for two separate areas. We have air, ground, and flight. But first, I'm going to start a little bit about what mobile integrated healthcare is, or MIH. Mobile integrated healthcare is a proactive, community-based program that leverages EMS to bring patient care back to the patients. Instead of having patients call 911 to be transported, this program really, and as Melissa mentioned, if you've seen one, you really have only seen one, because every community is a little bit different. But the commonality of it is individuals who are driven to bring patient care back to patients, whether it's a CHW, an EMT, a paramedic, a community paramedic, all levels. And they're normally 95% of the time housed or employed by an EMS agency. So the MIH is bringing the right care to the right at the right time. This could be anywhere. It could be for us in Southern Oregon. It could be on our greenway or in a park. It could be in an elderly person's home. It could be in a brand new parent's home. It could be an apartment. It could be up in the rural, in a cabin. It's anywhere. The goal is to provide preventative care for the emergency and chronic care management. Some models like ours has some options of treat and place. The other unique thing about these programs is they are coordinated with all the invested parties and stakeholders within the community. So the goal is to reconnect the patients back to the providers, make sure they have a medical home, and make sure the patient's taken care of for the long term. And then it's equity focused. For qualify for most of these programs, there really isn't a qualification other than the need is there. They don't need to fit into a checkbox or have a certain diagnosis. We'll share a little bit about how we get patients, but most of the time at most agencies, what I've heard of across Oregon and the US and the world, they receive referrals from all over in the community, and they're community-based. Next slide. So a little bit about our story. We started in 2016 in Jackson County, and my background is I started off as a ground paramedic, and I was lucky enough to transition into this role. I fell in love with the idea of mobile integrated healthcare or community paramedicine, which you might hear in a little bit, back in 2009. And so when this opportunity presented itself at Mercy Flights, I'm probably one of the very first people who applied. We started focusing on high utilizers of EMS and ED, and since then, we've grown to offer a significant amount of services. We are focused only in Jackson County, so we serve all parts of Jackson County, including Ashland to Rogue River, up to our frontier communities at Prospect and Butte Falls. And then our mission is really to improve healthcare access outcomes to our high risk, high need, and underserved community members across Jackson County. We'll talk a little bit about our retention and recruitment, but we are a multidisciplinary team. We are staffed with community health workers, EMTs, paramedics, and those that have received the additional certification of community paramedics. And we all operate under our position, our medical director standing orders. Next slide. So our team is multidisciplinary. We have, as I mentioned, part of our recruitment strategies we began in 2018. Our initial push was to cross-train the paramedics that we had on staff as community health workers. And it really wasn't for anything other than understanding where the patients are coming from, since we were always in the mindset of 911, an emergency. So we really wanted to learn more about what was impacting a patient's health. In 2020, we were actually able to add 2 full-time community community health workers to our staff, and that is still the model to this day. So we recruit EMTs, paramedics, community health workers, and we allow them to work at the top of the scope. We provide the additional training, advanced interventions. We work alongside of our local college and our hospital and clinics to receive the additional training. We have a very innovative and progressive medical director who sees the need and is very passionate about mobile integrated health. So she supports the work that we do and is working constantly to try to figure out better ways that we can impact our patient care. We work with all of our clinic partners, but we have some really strong partners with our local FQHCs that see this vision and see the need. The other part of our program we started in 2022. We are the second half of our mobile crisis team here in Jackson County. So this is teamed up with mental health providers and our MIH team. And then, which is really unique because it allows us to bring in individuals who have the background of a qualified mental health assistant, or they're working on moving on and continuing to grow their career as an LCSW, or wanting to become a master of psychology. So they have this drive and the passion. And then we work really closely with our CCOs, or the coordinated care organizations. Our biggest partner down here in Jackson County, because this is their area, is Jackson Care Connect, which is part of Care Oregon. And then we work with all community partners. There's not one that we don't work with, from law enforcement to fire to the FQHCs, as I mentioned, to our social determinants, which is access, or those patients that needed food insecurities, to our disabilities. And then we are integrated into collective medical, or point-click care, and that helps us track our patient outcomes, receive referrals, and then really look at utilization. And then we'll share a little bit about this for the Oregon MIH Coalition and what our goals are, but our team also has 5 of the certified community paramedics in Oregon. And so the goal is, if they want to pursue that education, we're going to support them. We're going to help them get that education, along with some grant funding and scholarships, and continue just to promote them. So when we're talking about recruitment, we really allow our individual team members to spread their wings, seek opportunities to grow, and they are excited to continue to expand their scope of practice. Next slide. So as we mentioned before, we have a mobile integrated healthcare program, but underneath it we have a number of programs. One of our largest programs is our transition from hospital to home. This is supporting patients that are discharging from the hospital after an admission. And then traditionally, for patients to receive follow-up, they would need to qualify for home health. For patients that are in our program, they just need to have an admission into the hospital, and they need the additional support. So we follow up with them post-discharge after meeting them in the hospital. We have our community outreach programs, which is a variety of different patient population, but really it came to light in 2020 when COVID started. And then unfortunately, we ended up having the Alameda and Obenchain fire, which is a little reminiscent of our times that we're in right now, but we had a pretty significant fire that came through a couple of our communities. And our community partners, along with Mercy Flights, came together and said there has to be more we could do for our community. So we started working alongside law enforcement, because we lost nearly 3,000 homes in that fire, and we had a significant amount of increase in houseless population. So we really tried to work to figure out what we could do to find a creative approach to taking care of patients. Again, we still work with unengaged patients, those that are not engaged with primary care, that might be using the ED as primary care, and are high utilizers of EMS and the hospitals. So we work to come up with care plans for them to make sure they have the wraparound care, everybody's on the same page, break down any communication barriers of what's happening in the community versus what's happening at their primary care to the hospital. So we work together to make sure they're supported. We also have an IV antibiotic step-down program, which is really unique. It allows patients that would need an IV antibiotic through a central line, a peripheral line, either on a pump or need to be injected once a day, that also need residential inpatient substance use treatment. Traditional models, the patients would need to stay in the hospital for up to 6 weeks, missing that very vital opportunity to get them into treatment, engage them in services, and help them start their path to being sobriety. This program allows us to these patients to discharge up to 6 weeks earlier from the hospital. It allows them to get into the treatment and the engagement that they need, and we provide the treatment within the inpatient facility here in Jackson County. It also is, well, trifold, I guess. It also frees up a bed within our hospital. And like everyone around Oregon and the nation, one of our local hospitals just shut down. We're all really at max capacity. So that one bed is a vital solution for some of our patients. As I mentioned, we are also the second half of Mobile Crisis, which is in Jackson County. This began in 2022 when 988 was being launched. We worked together with our local mental health providers and we did community engagement meetings. We asked stakeholders, we asked those with lived experiences, law enforcement, fire departments, anybody who would engage in individuals that were in crisis, and asked our community what they wanted. And so we created a really unique model. We partner with our county, mobile crisis, or our mental health facility, and then there is us. And so when there's a call that is received through 988 or 911, we will respond to help de-escalate the situation, allow individuals to stay home, and law enforcement is also able to call us directly from the scene that they may have got on scene and realized this is not a law enforcement issue. I have a resource. They get us out there and we can help take care of them. We also started vaccine clinics along with 2020 with COVID, but now we've continued that process on to this day. And I'll be very honest with you, this is one of my favorite programs because we get to take the flu and COVID vaccines out to our rural and our frontier communities. And we've been doing this for about 4 years. And we have some of the most unique residents that come up, and the only medical attention or intervention they get from any provider is us once a year when they get their vaccines. Let's see. And then, of course, the disaster response program. I think it came about 2020 seemed to be a pretty pivotal year for us. We helped with the evacuations, and then we helped follow up through the shelters and helped individuals get their medications and food post the Alameda Open Chain Fire. The two new programs that we started this year, which I'm excited to share about, one is our post-overdose follow-up buprenorphine induction program, which our entire agency has been trained on. If we come across an individual who's experiencing an overdose, they can reverse the overdose with Narcan or naloxone, and then they can offer the patient the first dose or second dose of buprenorphine, which there are very few agencies in Oregon that do this, let alone across the nation. And then they can also provide alternate transportation. We have some partners in our community that are willing to we have 3 that are willing to take patients during normal business hours. And then, as I mentioned before, we have a very forward-thinking medical director. So she has trained the local ERs that if these individuals show up, they can help support it. The referral will automatically come to our team, and then we will help follow up with them to make sure they have continuation of care. That also, along with that, we partnered with Save Life Oregon, so we're able to leave Narcan leave behind. Again, our entire company is trained on that. We also have harm reduction supplies, drug testing kits, really just to make sure our community is safe. And then the last one that we started in February, which I'm excited to share about, is our in-home emergency care program. We partnered with a company back east. They're called Instead, and they are our virtual medical control. They've been doing this work for a bit on the East Coast. And what we are doing, we're doing a little bit differently. Instead of individuals or agencies calling to ask to have a patient checked out, our team is actually actively working within 911 and looking at lower acuity calls, those that are general illness or they have had a cough for a little bit. And we are taking the care to them. So our team has been trained and upskilled in providing the diagnostic tests, anywhere from pulling a lab right there and understanding their CBC or CMPs, and then they can do a COVID test or a flu test. And then they'll contact our virtual medical control, and they're absolutely the most wonderfully trained doctors and wonderful to work with. And they will give us the orders to either provide the first dose antibiotic. They'll help support the patient and call in medications if needed. But really, we have seen, we've kept, I believe my last statistic that I just saw was about 89% of our patients home. We're taking them out of real time, and 911, our team will respond, and then we get to treat them where they're at. This is a team right now of 2, but we're expanding it. We're expanding this to a team of 2 and then some individual teams that will go out to help offset some of the call volume on that. We will hopefully have more for this in our next presentation, I believe, in September. So it's very exciting. I'll go next slide. So just for time's sake, we can go ahead and skip just a little bit because we talked a little bit about this. One more. So for our results is, again, we have 7+ programs. Our patient engagement rate for patients engaging in primary care is significant. We work with Care Oregon to get some of our data back. We can help treat patients there. We reduce the amount of readmissions. And then again, like I said, we started in 2016 and we just continue to, our goal is to continue to expand and address our community needs. So just for time's sake, we're going to talk about the Oregon MIH Coalition, which is the next slide. This one I'm really proud of. I may be a little biased. I am so proud of the individuals that come to these meetings. They are individuals that work for agencies that are providing this care, and they all have the same vision. We are a not-for-profit. We began this coalition back in 2012, and just in the last few years, we formalized as a nonprofit 501c3. We have a full board. And again, these are individuals who are doing this work every single day. They have at least 2 or 3 other hats that they are wearing, and they're still showing up, and they're showing up from all over Oregon. Our goal is to provide equitable access to care across Oregon. Sorry about that. And again, we have statewide membership. I only have a few of the individuals listed here, but anywhere from Portland Fire Rescue to Mercy Flights, Caboose, Umatilla, and to the coast. There's individuals represented all over Oregon. This is the collaborative leadership. So we have leaders from learning facilities such as OHSU, fire departments, transport agencies, some of our locals or our state CCOs have representatives there, and then just individuals who really want to bring this care to the community. So it's a network that collaborates, they share protocols. Our goal is to improve health outcomes for all Oregon residents. And then as Melissa shared a little bit earlier, our goal is to help create up to 4 more MIH programs within Oregon. So we can go to the next one. So part of the things that I'm really proud that this the coalition has done over the last few years, Oregon has one of the, if you know much about what EMTs and paramedics can do, they have a pretty significant scope of practice. Oregon is also one of the last states, other than Kansas, that still requires an associate's to get a paramedic degree. They also have a really large scope of practice in how and what kind of treatment they can do in the home. And we have a very supportive Oregon Health Authority that is really wanting to help expand care. So with that being said, most of the presenters today are IBS certified, which is International Board of Specialty Certifications. And we've received the Certified Community Paramedic certification. I can tell you right now, that is probably one of the hardest tests that I've ever taken. It may have taken me twice. And when I started with this program, even in 2020, we only had 11 certified community paramedics in Oregon. Well, we were ranked, I think, the last in the US. And that really, there's only about 1,200 in the US right now. But over the last 3 years, with the support of Office of Rural Health, Oregon MIH Coalition, and agencies that are really trying to push this initiative forward, we've gone from 11 to 41. And this slide, I created these slides a few weeks ago, so this number may have increased by now. And our goal is to continue to add to this, which is going to build workforce, allow individuals to work at their top of their scope, receive additional education, understand what's going on with the patient and their care beyond the 911 call. And then again, I'm not going to steal Melissa's thunder. She's already talked about it, but we have received the HRSA grant. And so the goal is to continue to expand the MIH throughout the state. The pilot, which is in Wheeler County, and then working on more scholarships. We also have a strategic plan of creating a statewide toolkit for those that are interested in wanting to begin a program in their area and they're part of the coalition. We are putting together some operational tools to help stand up a program. some base protocols, because again, every community is a little bit different, and then really just help leverage it so they're not having to recreate the wheel because this work has been done for them. And then our goal is to help present and share this work a couple times a year, whether it's virtually, in person, whatnot. And I am really lucky that I get to present and share all the work that these agencies are doing, these individuals are doing, that I get to do at least once or twice a year. So we have a lot of very excited individuals across the nation that are interested in what Oregon's doing. I'll go to the next one. So lastly, I have, this is my first time of using my QR code. I did use it before. I can confirm that it works. But my contacts information's there for either you can get a hold of me there on Mercy Flights or through the Oregon MIH Coalition, which will make sure the website is on there. Feel free to come sit in for a meeting. We have one coming up in September. And then if you have any questions, I absolutely love to help and help agencies get going. So do not hesitate to reach out. And I'm on time, not taking anybody's time.
Thank you so much, Sabrina. Okay, we'll transition to Jessica.
All right. Well, thank you for all of that. Sabrina has actually been very amazing. She helped me a ton when we were starting our program here. And so her and Nina are both very fantastic. And I'm grateful that I get to do these presentations with them. So my name is Jessica Markham. I'm a community paramedic over here in Umatilla County Fire District number 1, which is the Hermiston area. So we cover 2 counties, Umatilla and Morrow, and we've been going for about 9 years. I want to skip to the next slide. So we started with 1 full-time employee, that's myself. We were originally embedded with community health workers at our local hospital, and that's Good Shepherd Medical Center. And we also had a part-time guy for a little bit. We had some extra equipment. And so the original goal of our program was we were going to address high utilizers out of the ER, and we were going to be partnered with a community health worker so we could meet both the medical and social needs of a patient. And we did that well for a few years, and then there were some changes within their program's called Connections. A few changes in their department, and we weren't able to see them on the timeline that was the goal of our program, and that's 48 to 72 hours of a referral. And so we no longer do co-visits together, but we still make referrals to each other. And yeah, it's been pretty successful. So one of my favorite parts of being with them was that if we went and found someone who was having maybe not an emergent issue, but more of an urgent issue, we could get a primary care appointment set up. They would help arrange transportation, whether that was with a taxi ticket or something like that. Or they could go pick up medications or get groceries or whatever it was. So still have options for that. We just don't do those together as much. We had a part-time position for a short time. Just due to funding, we ran off grants for the first 2.5, 3 years of our program. I'm very excited to say we don't have to run off of grants anymore. We do have a contract with our CCO or our Medicaid. It provides a little bit of funding, but the majority of our funding comes from our fire district. I'm very grateful they saw the value in our program and they've adopted into our budget. And in being in a rural area, sometimes you have a few different roles you work in, and this is my primary one, and I have a few others, but it's been very well supported with my district. We did have an iStat originally. That was actually really fun to use because we could really start to dial in on if someone was admitted for like high sodium, high potassium, maybe they were anemic, we could check to see how that was doing afterwards. And due to licensing changes with the FDA and CLIA and all of the lab testing, we don't have that anymore. But that's kind of how we got our start. So if we can go to the next page. So kind of what happens during a CP visit, I won't go too in depth into this, but it's kind of a little bit of everything. So we do a medical assessment and a social needs assessment. So we have a 4-page document that we go through and kind of figure out who's their doctor, what resources do they have. We do our depression screenings and substance abuse. We do a fire and fall risk one. That's kind of our bigger high utilizers, right? Are those individuals who fall at home and maybe they fall. We had one individual that fell, I think it was over 20 or 30 times in a matter of a few months. And they'd only been to the ER once. So their doctor got an ER report, but they had no idea what else was going on with the rest of that individual's life on a consistent basis. They'd actually fell and broken their coffee table. And they said, yeah, I'm doing great in physical therapy. They're going to move me from a Hemi walker to a cane. And we went, well, hold on a second. Maybe we should revisit that with your physical therapist. And so with those letters to the primary cares that I'll talk about in a few minutes, we can really coordinate care a little bit better for some of these individuals. So med reconciliations are a big one for us. There are so many medication errors that are out there, and it's not necessarily that people, and ones that they're not even aware of. So when you go into a hospital admission or maybe even an ER visit, your meds get changed. You might pick them up, you might not even be aware of them. And that's where we can really identify. I had one individual recently that had multiple ED visits and an admission. And in the course of, I think, 3 or 4 visits, she was represcribed a medication that she never knew was represcribed. And so once we were able to get that established with her primary care within the week, that utilization has gone significantly down. She hasn't called us since. So we do lab draws on a consistent basis, and disease and diagnosis education, discharge education. We have a screening to see what social services people are connected to. And then we also have another box of the same ones of what ones do they want to be connected to, or can we connect them to? So just identifying any of those things are the biggest. And then the connection to services would be our next one. And that's kind of the care coordination piece. If we skip to the next slide, is really where our program does a lot of. So when we get a referral, we start that care coordination process, whether it's before or after the visit. We do a full chart review if we have the opportunity. I am connected to Epic. So our program is a collaborative program with the hospital. With that being said, I have documentation privilege into Epic. And so I can see all the providers' documentation and they can see mine. And that has been so helpful in really getting a good picture of what's going on with this person. So I have all the EMS records as well, and then some of the dispatch records. So I can say, hey, we were dispatched to this address X amount of times. Here's what happened during EMS calls. Here's what happened when they went to the ED, and then when they were admitted, and then here's what happened after their discharge, and then they saw their primary care, and here's the follow-up that's going to happen afterwards. So you can really get that full picture of what's been going on with this person. What care did they receive? Do they understand that care? Do they have other resources? And then we can kind of make sure these things are like finding the medication of that wasn't represcribed or was represcribed that they didn't have. You can find those things much easier. Let's see, what else? We do some MBT meetings with some of that. I did get certified in doing MOCA testing. So that's a Montreal Cognitive Assessment. So part of what I deal with is individuals that don't have a lot of social supports. Maybe they wander, maybe they're not able to provide for their needs. So we work with a lot of those, and those I can tell you are extremely time-consuming processes of trying to figure out what's going on in this person's life, because maybe they aren't able to tell you because they don't have the cognition, and where are the medical records, and then what are their interactions with law enforcement and EMS, and how to get those people safe. So with all of that, I found you really have to be an expert in your community and your community resources. Next slide. To make some of that happen. So kind of like Sabrina was saying, there's not a service we don't work with necessarily. It's really that care coordination aspect that I think our program has thrived off of a little bit. So whether it's the hospital or community mental health with their different teams, RCCO, home health and hospice, some law enforcement stuff, adult protective services, and I are kind of on a first name basis for the most part for a lot of cases of self-neglect usually. Next slide. Oh, there we go. So part of our visits is we send a letter to their primary care or their surgeon, depending on what the issue was that we saw them for, saying, hey, we saw your patient, and then here's a little bit about them. And so that goes into their medical records. And so I have a few different paragraphs in it, usually one that includes what their living environment is like, what their social support system is, if they have, if they have like assistive devices, walkers, wheelchairs, if they get Meals on Wheels and home health and whatever services those could be. Next one's kind of that O part in a normal EMS chart of, this is how I found this person, here's their physical condition right now, here's any wounds, if they have any infections, that sort of thing. Then I go into any concerns that the patient has, and then we could have some additional paragraphs in there of dispatch information as far as how often they're calling 911, if there was any major issues found, stuff like that. And then my last paragraph that I usually bold and move to the top because no one wants to read through my pages of documentation at times is just a summary of, here's the top couple things I want you to know about your patient. So those have been really, I think, a huge part of why I've gotten a lot of cooperation with our primary cares and surgeons and at our local hospital, because I didn't originally have access to Epic. I started this program with Word documents, and I had to format every single one to make sure it fit on the page, and then I'd fax it off to them. And then with some of those, they went, oh, okay, so you saw my patient, and who are you? You can do what? And that started to get more questions of, well, if you did that, can you do this? Like, I have a person who can't get in today, but I'm kind of worried about him. Can you just go take vital signs? Oh, hey, well, they had some high sodiums. Can you go draw some labs for me, or whatever the case would be? So with all of that, we've got a lot of cooperation with primary cares in our area, just from being able to have those services that can be done quickly. So, and then they get the feedback as that closed loop communication, right? Of, you have a patient, maybe you send a referral, here's everything that happened during this visit. And that really has been so helpful. And they've been very helpful when I do call, because they usually know it's for a good reason. So next slide. So what makes us unique? I know a lot of programs use Image Trend or the Community Health Module, Gelada. There's a few of them out there. I am not the only one, I think, that has Epic access, but there's a few programs, I think, particularly that don't. And I just can't encourage enough, if you have the opportunity to connect with your local hospital and at least get read-only access for that care coordination, it gives you a much better picture of your patient and what's been going on with them, what they're supposed to have, what they can have, what their instructions are. We're able to provide that wraparound care. And not that other programs don't. I think we all have a pretty good niche of knowing what our communities have. But we've had some really good partnerships. And with that Epic access and documentation, I can spend quite a bit of time on a single patient, sometimes days or up to a week or two at a time. And not fully consistently, but fairly consistently. Because there's so much that goes into these. I've found that as a paramedic, I didn't think I'd be looking into legal processes and civil commitment stuff, and partnering with mental health, and coordinating with adult protective services and the hospital and whatever other agencies are involved in this person's care. And when you have someone that can dedicate the time to understand what the systems are, what they do, that nobody's not trying to do their jobs, but we're all working within rules, but we don't know what the rules are for other agencies. You can really get so far with somebody and getting them the services that they need and the connections that they need if you can start to understand just a small part of their process and ask good questions. So that's been a lot of my job that I didn't plan on ever doing when I first started this. And then just the access to so many community partnerships has been huge, because we don't do this alone and we need to lean on those community partners. And so I did a lot of time trying to figure out who does what and when, and that's been helpful too. So next slide. And why this work matters. This is probably why I get very passionate about this. Next slide. Is when we were looking for in between grants until we got off grants, I had a letter of support that one of our fire chiefs wrote at the time. And the short version of what he wrote here is he's been in the fire service for 31 years, and he was very impressed with how our program operated. As an emergency responder, he's witnessed many calls that need just a little extra help or direction, or those people that don't want to be a bother. And unfortunately, it results in poor outcomes, poor care, or worse. And unfortunately, as emergency responders, we have not known how to help or where to direct people. And so he talks a little bit more in that, but the short version is when we are able to come alongside our first responder agencies, we go from we don't know what to do, but you're not dying and it's not an emergency to, hey, there's something here for you. And when that goes into recruitment and retention, you take people that are stressed out because they don't like leaving someone in a bad situation to, we have options for you. So when we've been doing some of our recent hirings over the last few years, I've actually been really surprised to hear that we've had people saying, hey, I heard you had a community paramedic program, and that's part of the reason I want to come to your agency. Or you have people that aren't getting as burned out because they're not going on the same people over and over and over again for non-emergent reasons, or it's a really bad home environment and we don't want to keep going into those. So I'm running out of time and I'd love to talk to you all more about this, but it's really about having people feeling like they're part of the solution. And so if I can give you one last story is we had a law enforcement agency call me the other day. They called dispatch, said, hey, can you dispatch a community paramedic, which I'm not typically dispatched to things, but they had an individual that was obviously unsafe, was incontinent, was wandering, getting lost, and they're a person that's going to get lost in the system. They didn't have mental health criteria, possibly that we knew of. They didn't really know much about him. He's not a good historian. He could go to jail for disorderly conduct, but that's really not the right place for him. So what can we do? And so in working with some other systems, we're able to get him to the hospital, get him some services. He's in a safe place right now, but what do we normally do with those cases? Nobody knows. And being able to call someone who has those answers provides so much relief for all of our first responders. And then when I get referrals, especially from our people, I'll give them that feedback of, hey, I got your referral. I saw this person. This is what's happening with them. And then they don't carry that weight with them, for days or weeks. So I think I'm out of time now, but that's kind of when we talk about retention and recruitment, that's really where I feel like these programs can thrive and shine. And there's my contact info if you have any questions.
Great. Thank you so much, Jessica. And then we'll finish our time with Nina whenever you're ready.
Hello. So I'm going to just ride on the coattails of Sabrina and Jessica, and hopefully we'll have a slideshow for you. I've been working since 2017 in Columbia County as a community paramedic there, and have learned an awful lot and have benefited an awful lot from my association with the MIH Coalition and Sabrina and Jessica and our colleagues there. Next slide. So a year and a half ago, I got a colleague, which means that I wasn't carrying the community paramedic on my own shoulders, which was great. She's the one who looks human. Next slide. All right, so it started in 2017. It was intended for high utilizers, supported by the Columbia Pacific CCO. And as it developed, we incorporated the Institute for Health Improvement quadruple aim, as well as well, let's go to the next slide and that'll show you what that aim is. So improve the patient's experience of care, including satisfaction, improve the health of populations, and that is important in terms of the equity that Sabrina mentioned, reduce the cost per capita of healthcare, which of course is very interesting to medical coverage, and in terms of recruitment and retention, protecting the well-being of providers, which is huge. Next slide. So we cover all of Columbia County, all departments. We do an awful lot of roller skating to support well-being as well as, health. We don't carry our clients around, however. Next slide. We get referrals through the CPCCO. They have a regional care team, which is allied health agency people and community partners, and we discuss the needs and the conditions of our clients and patients. We work very closely with local clinic staff. We do a lot of outreach and deliveries for them. We find people they can't find. We train people with the stuff they need training in, including medication. The crews know the needs of the county residents better than anybody else because they are in their environments and their situations all the time. We get an awful lot of referrals from the line crews. Next slide. So we also get them from where everybody else gets them. The community action team, the churches, families, hospital social workers, discharge planners, adults and people with disabilities, adult protective services. And we are very happy to use community partners as community resources because, as everybody points out, it takes a village. And to prove that this is very individual community based, of course, even the dog catcher has referred clients to us. Next slide. So this is what we do like everybody else does, not wound vacs. Next slide. We do more stuff. We do a lot of pickup and delivery. We do a lot of patient advocacy with their appointments and in hospital as well, even on hospice patients. And we pick up and deliver things that they need, medications, durable medical equipment. We are partnering with a local clinic to hand out free ride vouchers because transportation is a huge problem in rural counties. And then we do a lot of education as requested. Next slide. We will accompany partners into their homes because we have radios and we get pinged for safety's sake. And then we do respond to 911 calls with the line crews and sometimes in place of the line crews if the system is stretched and it's possible for us to prevent a call. We do not go into unsafe situations. We don't work with chronic pain patients, and we don't do behavioral health therapy because we're not trained in it. I wish we had mental health people to accompany us. Next page. But we do have a therapy dog. Next slide. Okay, so we have access because we are embedded in a fire department to can-do providers. So they can help us with an awful lot of problems. And the picture on the right is somebody dismantling a staircase so we could get an extraordinarily large and vulnerable person out of the house. We could not have gotten her to medical care on our own. And this is one of the reasons that being embedded in a fire department is very, very handy. And it's also safety for us. Next slide. Sorry, we're galloping here. We try to decrease the number of unnecessary 911 calls and transports, and that's part of the retention that we're trying to provide to our responders. And as Sabrina said, these people can refer us to residents who they feel need resources or even just tender loving care, providing care beyond the 911 call. Next slide. So as we work to protect our clients, we also try to protect the well-being of providers. We are accessible to them, and as Jess pointed out, we provide follow-up for them, which is rare in the HIPAA training, environment today. That's good for training, and it's very good for their morale. They feel empowered. They have a sense of agency in serving the community. They can walk into a scenario and not feel helpless and not feel the weight of it, as Jess pointed out, because they can come back to Susie or me and say, hey, this person needs this. Can we make this happen? And that, guarantees that they have provided more to the community than transport if necessary. And it's also good for them because we bring feedback to them and to their superiors, which is almost always excellent. And I know that people do jobs for money, but people also really, really need to hear when they do those jobs well and are appreciated by the community. Next slide. So we can help our crews by giving them information about situations or attitudes or challenges that perhaps would not otherwise be available because we're able to spend so much more time with our clients, their patients, than they can. We can follow up with educating their patients and assistants with the other resources to try and decrease the burden of 911 calls. And of course, if you're scooting around in a marked vehicle doing good things, it's really good publicity for the department. We also can respond, as I said previously, sometimes crews will call and say, look, this person really does not need to be transported. Can you help? And we do. We can stay on scene for as long as is necessary to assist the patient and address and link them to resources. We do respond to falls, which I want to add here in Columbia County. Falls is the #2 driver of 911 calls here. We can help uninjured patients up. We can educate them on how to get up. We can save resources for other emergencies, and we can, start to work on getting DME like grab bars, walkers, and all the rest of it, ramps through community partnerships. Next slide. To summarize, we work to enhance the health and well-being of our communities based on the needs of the individual communities. Every CP program is different. And we work to protect the well-being of the 911 response crews as well by giving them more agency and more power to affect the outcome of people who may or may not need transport. We benefit from and we contribute to the service culture of the organization, which I think is huge. We try to diminish the burden of calls, and we improve the community's view of the department we work in and preserve as best we can the morale, resilience, and staying power of our colleagues. Next slide. Anybody have questions?
Thank you, Nina. That's a perfect segue to our last portion. We have about 4 minutes. And want to first just again, thank you so much, Sabrina, Jessica, and Nina, for sharing all of your expertise and experiences with mobile integrated health. We do have just a couple minutes for questions. We have one more slide after this with just a few updates and announcements. So we'll leave a couple minutes for that. But if you do have any questions for any of our presenters, please feel free to put those into the chat. And we are happy to field any questions if there are any. Please also know if you are looking to the chat, there is Joan added Sabrina, Jessica, and Nina's contact information. So please do also feel free to reach out if you have specific questions for them about their programs or anything that they shared today. And Sarah, I see we have someone who has their hand raised.
Someone has a question?
I saw a hand raised.
Might be me, if that's kosher. This is all incredible, top to bottom, absolutely, completely incredible. And I'm wondering about the barriers. It sounds like everybody's thought about incorporating peers more into this and patient health navigators, et cetera. And I'm wondering if there are any obvious barriers that we can start trying to break down to allowing you to have peer support services, et cetera, on some of these calls.
Any of our
So-
presenters? Go ahead.
Sorry, I was trying to find my mute button. So for us at Mercy Flights, we do take peers out from our local behavioral health or substance use. We do not employ them, but we partner with them. I think as everybody, we really work closely with our community partners. Agreed.
Same. We work with our peer teams with our community mental health.
Melissa,
What
there's a
they
question. Oh, sorry. There's a question in the chat that says, can you bill?
So Nina from SCAFU's here. Our program is completely funded through the Columbia Pacific CCO, so it is free to any county residents, and we don't bill because we're totally supported.
And I think that's a good question for Sabrina too. I don't know if we can legally bill for our services, but we can have invoice certain CCOs. I know with ours, but I don't know if anyone has figured out a billing mechanism specifically for community paramedicine or MIH yet in Oregon.
So we're working really hard as the coalition to push that forward. We worked on it last year. We got passed through. We got all the way to Ways and Means. Unfortunately, in 2025 last year, there were a few other pressing issues. So we plan to go back to push through the bill, if you want a little bit of reference, was House Bill 2222. Our goal is to take that back to the long session next year and represent it. What it will allow us to do is those that have the education that meet their criteria, the OHA is working to try, our goal is to create a registry, and those individuals that are in that registry will be able to bill for the services that are identified by Medicaid. So we will not be creating new billing codes. We will not be adding more, creating more work, but we will be able to prove that we have individuals that have the right education in the right community that are able to or bill for those services. But as Jessica mentioned, a lot of agencies across Oregon that are doing this work that do receive reimbursement is through an invoicing or direct contract.
Thank you all. And unfortunately, we are running short on time for additional questions. So again, please feel free to reach out to our presenters with more specific questions.
Yeah, and I'll just add that these links to the what is on the screen right now will be available when you go to the website and get the event post. Once it's posted, these links will still be live. You'll have a recording, and then you'll also have the slides, so they'll be available.
Great. And on this slide is contact information for myself and Joan. Please feel free to reach out with any questions or if you have any interest in learning more about anything you heard here today. Another thank you again to our presenters, and thank you so much to everyone for attending today's community conversation.
Phenomenal information, guys. Great.